Hello, this is a series of therapeutic problems, better known as explain why. So, the first is the atropine installation into the eyes generally is avoided in glaucoma patient. So, what is atropine? Atropine is an anticholinergic medication. First, you have to write, right? That increase the IOP, intraocular pressure, by blocking the parasympathetic nerves that controls the iris and the ciliary body. Okay, this is the most important thing. Now this that parasympathetic nerves it get inhibited. Okay, and here the optic nerve damage may occur. Okay, so the first point is this. The second point, still where installation of atropine can be done. Okay, so number one, in which places? So first is the treatment of uveitis, and second for diagnostic procedures like fundus photography or optical coherence tomography, OCT exam. Okay, in the uveitis basically is inflammation, so atropine can reduce the pain and inflammation in uveitis patient. Okay, so I think this is what you have to write, why atropine is not used in glaucoma. It is just avoided, but which places it is used, that is written. Okay, again, if it is used, atropine is used, then it should be carefully monitored. It should be closely monitored. Okay, so it increases IOP by inhibiting the parasympathetic nerves that controls the iris and ciliary body, ultimately leading to optic nerve damage. Where it is used, treatment of uveitis and diagnostic procedures like OCT. What is OCT? Optical coherence tomography. Okay. Second question, what changes in the eye may occur when atropine, okay, is dropped in the eye? So what are the things which we are going to see? Let's make a list. Number one, mydriasis. Okay, so what is mydriasis? Is pupil dilation due to paralysis of the iris sphincter muscle. Okay, what is number two? Cycloplegia. What is cycloplegia? It is paralysis of ciliary muscles leading to loss of accommodation or the focusing ability. That is the cycloplegia. Third is the increased intraocular pressure. Like we discussed, the atropine causes temporary increase in IOP due to decreased aqueous humor outflow. Okay, by inhibiting the parasympathetic nerves that controls the iris and ciliary body, and if there is a decrease in aqueous humor outflow, there may be optic nerve damage. Okay, number 4, there is blurred vision. Okay, due to loss of accommodation and pupil dilatation. Okay, that's why atropine is contraindicated in adults. Okay, it is used in children. It is contraindicated in adults because it will cause blurred vision, and the patient will be unable to drive. Okay, or it will be a blurred vision for the whole day. So, and for the children, it will be a smally blurred, but in children the iris muscles are very strong, very stiff. That's why it is used. Okay, so in adult, mostly tropicamide is used. Okay, for refractive testing. Okay, but for not refractive testing, only for visualization of the retina, for retinoscopy and all. And you will learn more about this in your ophthalmology classes. Now, What are the other things atropine can do? It can cause dryness. Atropine can uh, reduce the tear production, leading to dryness and discomfort. Next is photophobia. Photophobia leads to increased sensitivity to light. Okay, because of the dilated pupil. More pupil is dilated, what will happen? It will get more light. Okay, it will attract more light, and which leads to photophobia. Okay, then there is flushing. Okay, atropine can cause blood vessels in the conjunctiva to dilate, leading to redness and a reddened appearance. So it will be reddish. Okay, so I think these are the important changes which you see in the eye. Now, next question: how neostigmine reverses the action of D-tuberculosis? Now, neostigmine is a anticholinesterase agent. It reverses the deep tuberculosis, that is the non-depolarizing neuromuscular blocker. Okay, so what are the examples of non-depolarizing neuromuscular blocker? It is the D-tuberculosis and pancuronium bromide. Okay, now how what is the mechanism of action of A, right? The first is the inhibition of acetylcholinesterases. So neostigmine inhibits the enzyme acetylcholinesterases, which breaks the acetylcholine in the synaptic cleft. Second, it increases the ACH levels. So with increased acetylcholinesterases inhibited, acetylcholine levels increase in the synaptic cleft. Okay. The third is the competitive antagonism. The increased ACH compete with the ND-MB, that is the non-depolarizing neuromuscular blocker. Okay, so it will compete with it. Okay, at the neuromuscular junction. The fourth is the displacement. It can also cause displacement of the NDNM blockers. And the fifth is muscle contraction. Okay, now if it is like if the NDB is replaced, okay, now what will happen? The muscle can contract again, restoring the normal neuromuscular function. Okay, now this reversal is crucial in some clinical important settings. Number one, where it is used, this phenomenon, where you are going to see. So after any surgery, reversing the neuromuscular blockade after any surgery. That is the first. The second is after surgery, or second is the managing the toxicity after surgery, toxicity or overdose from the non-depolarizing neuromuscular blocker. The third is in some condition like myasthenia gravis. In myasthenia gravis, okay, where the neuromuscular transmission is impaired, so there you can use it, right? Now, neostigmine does not reverse the reverse the succinylcholine or decamethonium induce the skeletal muscle relaxation. Neostigmine reverses the tuberculosis or pancuronium, okay, but it does not reverse the succinylcholine. How and why? Okay, so see, first, succinylcholine, you have to know succinylcholine has a rapid onset of action. And short duration of action. Rapid onset and short duration, okay, like 4 to 6 minutes, okay. And pancuronium, on other hand, was having a slower onset and longer lasting action for 20 to 80 minutes, from 20 to 80 minutes. So here comes the catch, okay, that neostigmine reverses the non-depolarizing, but succinylcholine is basically what? It is a depolarizing neuromuscular blocker. So succinylcholine is a depolarizing one, okay. Pancuronium was the non-depolarizing one. So what will happen? Succinylcholine works by persistent activating the nicotinic acetylcholine receptor, causing the prolonged depolarization and muscle relaxation. So neostigmine cannot reverse this effect, okay. So succinylcholine is rapid onset of action and short duration, right? And what does the succinylcholine do? It works by persistently activating the nicotinic acetylcholine receptor, causing prolonged depolarization, okay, and muscle relaxation, which cannot be reversed by neostigmine. The second is succinylcholine. um, uh, Succinylcholine often used in endotracheal intubation, okay, and other like electroconvulsive therapy, okay. So here the action is very rapid, okay. It's so rapid that there is no time for neostigmine to actually compete and displace the succinylcholine, because it uh, like when it goes, it's actually like already destroyed, right? And already the work has been done, and so I think this you have to understand. This is one of a typical question can be asked, huh? Now, neostigmine but not physostigmine is used for myasthenia gravis, okay. Physostigmine is a reversible cholinesterase inhibitor, okay. And so so neostigmine and physostigmine both are reversible cholinesterase inhibitor, okay, that increase the acetylcholine levels at the neuromuscular junction. The problem is that neostigmine is a neostigmine is a quaternary ammonium compound or structure, neostigmine, and physostigmine is a tertiary amine, okay. So neostigmine cannot cross blood-brain barrier. So no CNS side effect, whereas physostigmine has actually poor tolerability, and it crosses the blood-brain barrier, so causing the CNS side effect. So I believe that you are understanding this basic things, like how and why you can use this typical structure related questions, and how you can be explaining the typical therapeutic problem, right? Now, ephedrine shows tachyphylaxis, okay. So ephedrine increases the number one, receptor sensitization. The term is receptor desensitization. What means that repeated stimulation of receptor by ephedrine leads to desensitizing, making them less responsive. making them less responsive. And number 2, it increased metabolism. So the body adapts by increasing metabolism of ephedrine, reducing its effective concentration. Now, what I mean is, suppose 10 microgram of ephedrine is given. Okay, so suppose it shows a response. Okay, within 5 minutes, if suppose another 10 microgram is given, the response show will be lesser than the previous one. Okay, because of receptor desensitization, and this is the fade phenomenon, kind of a fade phenomenon. It fades out. Okay, it fades out. So on even repetitive stimulation with the same dose, okay, the effective concentration of ephedrine is decreased because of the increased metabolism and receptor desensitization. Okay. Next, sympathomimetic amines should not be used as nasal decongestant for prolonged use. Okay, why it should not be used? Because of rebound congestion. In congestion, the nasal passages become dependent on the decongestant, leading to worsening of the congestant when the medication is stopped. So there is a rebound congestion. The second is tachyphylaxis. That is, the nasal tissues become less responsive to the decongestant, reducing its effectiveness. Okay. Third is the nasal mucosal damage. So prolonged use can cause damage to the nasal mucosa, leading to chronic congestion, dryness and crusting. Okay, foul smell can also come. Okay, so what is how prolonged, like what is the normal? So American Academy of Otolaryngology, okay, recommends that sympathetic nasal decongestant should be used for 3 to 5 days for oxymetazoline, and 7 to 10 days for phenylephrine. Okay. So nasal mucosal damage is the most important part. The crusting part, where I said that congestion, dryness and crusting, okay, leads to awful smell. Okay, and what is this called? This is asked in Viva. Called atopic rhinitis. It may cause the atopic rhinitis. It is a famous question in the ENT, that use of any drug may cause atopic rhinitis. So the answer is yes, oxymetazoline for the prolonged use, that is, or the nasal decongestant on prolonged use can cause this. Okay, now MAO inhibitors and sympathomimetic amines should not be administered simultaneously. So it is a drug interaction. So what happens if both are used together? Now MAO inhibitors are you have to understand there are a lot of MAO A, MAO B, right? And I'm not discussing all, but administering both can lead to hypertensive crisis. How? MAO inhibitor inhibits the breakdowns of tyramine. Tyramine is a naturally occurring amino acid, okay, that increases the blood pressure. Okay, as well as sympathetic amines also increases the blood pressure. If both increases the blood pressure, overall it may cause typical hypertensive crisis. Number 2, okay, there is something called cheese reaction. Okay, now number 2, serotonin syndrome. MAO inhibitors can increase the serotonin levels. While sympathomimetic agents can also affect the serotonin levels. If they both are mixed together, they have a serious life-threatening serotonin syndrome, a condition where there is high amount of serotonin presence. Okay, so what are examples of MAO inhibitors? It is phenelzine, tranylcypromide, isocarboxide. Okay, sympathomimetic agents: oxymetazoline, phenylephrine, pseudoephedrine. Okay, so this is now methadone is useful for the treatment of morphine, heroin, or pethidine addict. Okay, so methadone, what it does, it is useful in the treatment of morphine, heroin, or pethidine. Okay, so methadone can help manage the withdrawal symptoms and reduce cravings in morphine addict patient. Now heroin, it is used as a substitute to reduce the withdrawal effect, withdrawal symptoms, withdrawal effect and craving. Okay, in pethidine also it is a it how it does actually, it increases craving, decreases craving and all. So how it works, it actually activates the opioid receptor. Methadone binds to the opioid receptor in the brain, reducing the withdrawal symptoms and craving. Number 2, reducing the withdrawal symptom like anxiety, insomnia, and muscular pain. Okay, the third is blocking euphoria. So it is reduces the intensity, blocking the main purpose of using opioids. Why opioids are addicted? Because of the euphoric property that decreased by methadone. Okay, so this is methadone is known as MMT, not make my trip. It is methadone maintenance therapy. Methadone maintenance therapy for opioid addiction. Okay, so what is how it helps? Number 1, it reduce the opioid use. Second, improve the health outcome, decrease mortality. And third is increasing the social stability. They stabilizes their lives, improve relationship, improves employment opportunities, and like this improves the social stability, Now it is a very important and very usually asked question. Adrenaline is used with the local anesthetic agent. Okay, so what are the local anesthetic agent? Is the lidocaine, bupivacaine, mapivacaine. Adrenaline with lidocaine is used for dental anesthesia and some skin surgery. With bupivacaine, it is used for regional anesthesia, okay, and pain management. Okay, for mapivacaine, it is used for skin biopsy and minor surgery. Now, why it is used and what it causes? Number 1, how it causes vasoconstriction. Adrenaline causes blood vessels to constrict, which reduces the bleeding and helps to localize the anesthetic effect. So it reduces the bleeding and localize the anesthetic effect. So reducing the systemic side effect. Number 2, prolonged anesthesia. As we have seen, localized anesthetic effect. Prolonged anesthesia, you can make another point. Okay, that increases the duration of anesthesia by reducing the blood flow to the area, allowing the anesthetic agent to remain in the effective area for a prolonged period. And the third is the reduced toxicity. It reduced toxicity by reducing the blood flow. Adrenaline can reduce the systemic absorption of the local anesthetic, minimizing the risk of toxicity. Okay, so yes, these are 10 explained whys, or more explained why. I'll make more videos, right?